Hello, my name is Mrs. Tinch. Today we're going to be talking about schizophrenia spectrum and other psychotic disorders. So we're going to start with the definition of the word schizophrenia is derived from the Greek word schizo, split, phren, mind. So schizophrenia is probably see the word probably, that means we don't know, but we have theories and research that back this up. We think it's caused by a combination of factors: genetic predisposition, a biochemical dysfunction, psychological factors, and physiological factors. So here's a picture of a patient hearing distressing voices, and it gives you an idea of what it's like to live with this disorder. Schizophrenia requires treatment that is comprehensive and presented in a multidisciplinary effect. So we're going to talk about that as we go on with this presentation. So the areas involved with schizophrenia, here's a picture and gives you some ideas. The ventricles are enlarged, the hippocampus is reduced, and there's atrophying of the brain. And more fluid, like hydrocephaly. So these are some, when you're doing some scans on the patient, you can do imaging to see structural changes that occur in the brain with somebody diagnosed with schizophrenia. And here is a good picture of a healthy brain and a brain with schizophrenia, and there's the enlarged ventricles. You can see the deeper crevices here and the smaller brain itself with more fluid. So, of all mental illnesses, schizophrenia causes more lengthy hospitalization, chaos in family life, exuberant costs for the government and people, and fear. They're marginalized in our society. We're afraid of what we don't understand. They're afraid of what they don't understand. When you talk to them, it's very challenging for them to function in a world when they're hearing distressing voices, which are positive symptoms, and then they also are experiencing negative symptoms. We're going to talk about that a little bit later in the presentation. So the nature of this disorder, it's a disorder of thought processes, how we think, perception, how we view the world and things around it, and our affect, our emotions. So here's a picture of our brain and how we get information in, and it's skewed in schizophrenia, and we'll talk about that a little bit more as we go on. Schizophrenia, there is severe deterioration of social and occupational functioning. Back to the diagnosis of mental illness. They have social problems, they have problems working, problems with interpersonal relationship. In the United States, the lifetime prevalence of schizophrenia is about 1%. Premorbid behavior of a patient with schizophrenia can be viewed in 4 phases, and this is important to remember. Phase 1, in that premorbid phase, there's social adjustment. They have antagonistic thoughts and behaviors. They're shy and withdrawn, poor peer relations, difficulty in school, antisocial behavior. Children, what we're realizing now through research, that children exhibit schizophrenia, and we give them other diagnoses because we didn't know that schizophrenia could be identified and diagnosed in children. We would say, they have attention deficit, or they have oppositional defiant disorder, conduct disorder. They could be put on the autistic spectrum, diagnosed with autistic spectrum, just because we didn't know. There's some physiological changes in children that may be in that premorbid state. Then we have phase 2. The The prodromal phase lasts for weeks to years. Deterioration in role functioning, social withdrawal, substantial functional impairment. They have problems with sleep, anxiety, irritability, depressed moods, poor concentration, fatigue. As you can see, ideas of reference, suspicion, and onset of psychosis. And sometimes patients are diagnosed with bipolar disorder because some of these diagnoses are very similar. These presentations are very similar, and they can get this misdiagnosis. We look at the DSM-5. I've talked about that in other videos that are giving us diagnostic criteria. And since we can't do a lab test, we have to go by the presentation of our patient. And that's why assessments are so important when we are trying to diagnose our patient. So then you have phase 3, that's schizophrenia, that active phase. They have delusions, hallucinations, and problems with work, their relationships are starting to suffer, and then self-care issues. We'll talk more about this as we go forward. And then the residual phase, what's left after that first psychotic episode. And they have a flat affect. Remember I told you their emotions and their interactions are skewed, and cognitively they have slowing, and that impacts their functioning and difficult to return to their baseline before their psychotic break. So basically, when you have schizophrenia, typically patients will have a change in positive and presentation of positive and negative symptoms, and don't go back to baseline because it is chronic illness. So prognosis, just like I said, return to full pre-morbid function is not common. When you're looking at risk factors for people that have better outcomes, all right, so people have good pre-morbid functioning. People have good support systems. They have good coping skills. They know how to manage stress and anxiety. They do better with this diagnosis. The later the onset, the earlier you're diagnosed, typically with research suggests that you're going to have a worse prognosis. Female gender have better outcome prognosis than males. Abrupt onset precipitated by a stressful event, associated mood disorder, and brief duration of active phase symptoms. So when we look at that, when we're trying to predict your outcome. Factors associated with positive outcome also: minimal residual symptoms, absence of structural brain abnormalities, normal neurological functioning, family history of a mood disorder, and no family history of schizophrenia. So when we're doing our assessment and interview of our patients, we're asking these questions. Is there a family history of a mood disorder or schizophrenia, so we can get a good baseline on our patient? Okay, so we talk about the disorders, and we started talking about post-traumatic stress disorder and other stress-related disorders. There's a genetic component. There's a growing body of knowledge indicating that genetic plays a significant role in the development of schizophrenia. And when we do our hearing distressing voices in week 4 simulation, you had opportunities to watch some videos about the twin factors and stuff that we talked about. One theory suggests that schizophrenia may be caused by excessive dopamine activity, which is a neurotransmitter. So we have nerves running through our brain, neurons. Neurotransmission occurs at these receptor sites, and these chemicals that are sending and receiving messages is skewed. When you when you are 16, 17 years old, there's a pruning process that occurs in our body, in our brain. Our neurons, our nerves are, we don't need as many nerves as we're aging. We needed those when we were developing from children until that adolescent stage. So the research suggests that the pruning process doesn't occur in that adolescent phase. And so they still have all these neurons and receptors and transmissions, and the messages get skewed and overwhelm the system. And, there's no circuit breaker then let's stop and restart it again. No. So that's what we think causes that. So we have medications to help with this. It's a chronic illness. There's no cure. And so the medications help with this neurotransmission. Could it be a virus? Could it be abnormal tissue or something wrong with your anatomy? Like we said, if we don't know what it's caused by, we just have theories and research that make suggestions could possibly be. And then, of course, there's some other diseases that could induce psychosis and schizophrenia. And they're all listed there for you. And researchers now focus on the study as a brain disorder. It's not a psychosocial disorder. It's not because you were raised in a challenging environment. That stress may have exacerbated the onset of schizophrenia, but that's not the root cause. It's biological. It's genetically transmitted. And if you have the gene, now they're thinking you're going to develop schizophrenia, which was a little different. They thought you had the genetic component, you had a stressor, and the two produce schizophrenia. Now we know if you have this genetic presentation, it is going to be predominant. It's not a recessive trait in our genetic makeup, which research is showing us, and that's good to know. So environment, of course, plays a part with schizophrenia, and it's been a lot of research shows that, but like I said, genetically, you may have been being raised by people who have schizophrenia or other mood disorders. Okay, and then we talked about this stress. And so it's like I just said that. Okay, going forward, there's different types of schizophrenia and other psychotic disorders. All right, delusional disorder is not on the spectrum of schizophrenia. They don't meet the criteria in the DSM-5. They have delusions of grandiose, that erotomania type of erotic, if you can see that. They have unhealthy relationships. They're jealous. They have they think people are persecuting them. And then the somatic type. So this is a delusional disorder. It's a psychosis. It's not on the spectrum. It doesn't meet the criteria for schizophrenia in the DSM-5. And then we have brief psychotic episodes. It's sudden, it lasts for a month, and you go back to your pre-morbid state. Then substances can cause us to have symptoms of schizophrenia. Of psychosis, not schizophrenia. And when the substance is removed, the behavior of psychosis dissipates. And then other medical conditions can cause schizophrenia. Catatonia can be part of a schizophrenia, but it can be a disorder of itself. Usually you see catatonia with schizophrenia more than with schizoaffective diseases. That catatonia is like a wax-like state. They have echolalia, where they repeat everything you say. Echopraxia, they mimic your movements. And when we talk about the symptoms of schizophrenia, we will talk more about that. And then other medical conditions can cause this. All right, so now let's talk about the different types of schizophrenia. This is schizophreniform disorder. This is something I'm seeing more in the psychiatric setting as a diagnosis. They have schizophrenia for been at least a year, 1 month, but less than 6 months. A little different than psychotic disorder. All right, so we talked about the different diagnoses, and now the next part of our lesson is going to be the nursing process. So please read your textbook to give you a deeper understanding of these different types of schizophrenia on the schizophrenic spectrum and different psychotic disorders.